right, so what I'm going to talk about in the next few minutes is two drugs should be the standard for older, frail patients. And I think that that is the critical question in the debate. It's not non-transplant eligible, because as you're going to see, non-transplant eligible really translates into older, frailer patients. And that's a different discussion than the one we have with many other of our patients. So how do we define older? Well, I think the European definition of greater than age 65 is not applicable at all. And so the idea that because you're 65 on your 65th birthday, you're no longer eligible for a transplant and you get relegated to melphalan-based therapy until recently, I think is shortchanging patients who are older. I think, in my mind, there are three types of patients. There's the younger patient, and that, from what I hear from my senior colleagues, that target keeps moving as everybody gets older and older. Not for me. But in general, younger patients are typically under age 70. Older, in my mind, is 70 to 77. And frail, which is the definition that I'm using for this debate, is patients older than 78. So in my mind, it's not really an age question, it's a performance status question. And when I see patients who are 74 and are surprised that I'm talking to them about a transplant, I say the oldest patient I've transplanted, and Paul may have different experience, was 78. I've got a couple of 78-year-olds that were fit as a fiddle and could outrun me in a 5K. I've got 55-year-olds that I say no transplant to because their performance status is so poor and they've got so many comorbid conditions. So age is, to me, not the best nomer. Now, one of the things that has always struck me is looking at this SEER assessment of survival by age cohort. And what I think you can see is significant improvements in patients younger than 50, 50 to 59, a hint of improvement for 60 to 69, but really no change for patients between 70 and 80. And this, to me, represents one of the real challenges. Is that because they don't get access to drugs? No. It's probably because they're so frail that until recently they couldn't benefit from some of those new drugs. And to me, frailty is really critical to improving the survival of these patients, because what we do has to be gentle enough yet efficacious enough to induce significant durable responses for these patients over time. Now, to speak to that question about older patients, this is data from Ajay Nook at our center looking at older patients transplanted at our program compared to SEER-matched controls. And the blue line are the SEER patients and the green line are patients at our center. And I'm not trying to tell you that everybody should come down to Atlanta, although it is a lot warmer. And we have a much nicer golf tournament a few weeks ago than you guys have up here in New York. But if you look at the correctly chosen aged older patients, you can see that they can benefit from high-dose therapy and transplant, and that it can have a significant impact on not just duration of remission, but overall survival. This is overall survival, to me, suggesting that there can be a pretty significant improvement, whereas SEER is somewhere around 2 years for older patients. In our cohort, it was well over 5 years, and this is relatively older data for us now. So again, I think age is in the eye of the beholder. Now, should we be relegated to substandard responses in patients just because they're older? And the answer is no. If you look at Antonio's data on age and depth of response, what you see very nicely is that CR does correlate with PFS and overall survival in patients treated with novel agents. So CR in terms of PFS and CR in terms of overall survival was clearly superior to what you see with the other response criteria. And if you take what I would call the really, really old patients, the frail patients, those over the age of 75, again, CR trumps both VGPR and PR in terms of progression-free and overall survival. So the endpoints should be similar, but the way you get to that endpoint may in fact be slightly different. So let's look at data that Ruben has presented a couple of times, and this is, I hope there's not a more recent presentation of this that I'm missing. This is from 2011. And this, I think, is a really important trial because Ruben's patient population for this was, in my mind, the phenotypic frail older patient. This was not just a European older than age 65 group of patients. These were truly frail patients who got either bortezomib dex, VD, VTD, or VMP. So 2 triplets or a doublet. And I think this is really informative because this trial was done in the US, so this is our own patients, this is our own data. And if you start to look at response rates, you can see they were almost identical between the doublet and the triplet. No statistically significant difference between the patients that got the triplet versus the patients who got the doublet. And if you then look at clinical benefit, progression-free survival, almost identical between the three arms. Again, suggesting in my mind that there was no added benefit for the 3-drug regimen in an older, frailer population. Now, this is using a proteasome inhibitor as the backbone. Many of you may use this, many of you may not, but this certainly to me is the first and oldest evidence we have that 3 is not better than 2 in an older, frailer patient population. And in fact, if you look at quality of life, you can see here the biggest reduction in quality of life actually occurred with the triplet of VTD, again, overlapping neuropathy in this subset of patients. So what about looking at IMiD-based combinations in this? And this, I think, is really exciting data. This is the largest randomized phase 3 trial ever done in myeloma. This is the first trial, or the MM020 trial. This was a randomized phase 3 of len low-dose continuously, len low-dose dex for 18 cycles, and MPT for a total of 12 cycles or 72 weeks. So the duration of the short limited therapy was the same in these two arms. Continuous therapy obviously was much longer. And what we know about this is if you begin to look at progression-free survival, again, 2 drugs was better than 3 drugs. No question that progression-free survival for the continuous Lendex arm was superior to what you see for the group of patients who either got short-term therapy with a doublet or short-term therapy with a triplet. And in fact, that translated to an improvement in overall survival. Green is 2, white is 3. So again, more evidence that not only is 2 equal to 3 in terms of response rate, but that 2 actually looks better than 3 in terms of progression-free and overall survival. That to me is really important. Why is that? Well, these are older, frailer patients. They're not the same as your 55-year-old who walks in and you can hit them with a sledgehammer and they're going to bounce back. This is a different patient population. Now, to further hit this point home, I think it's important to look at age. And one of the nice subset analysis that was presented at ASH this year from the first trial was looking specifically at age. And so if you look at younger than 75 or older than 75, there was a difference based on creatinine clearance of dosing of lenalidomide, mel, dex, prednisone, and thalidomide in this trial. And these are relatively standard reductions based on age or creatinine clearance. But again, if you look at the older patients, this is younger than 75, this is older than 75, 2 is better than 3. No question that progression-free survival favors the group that got the doublet of Lendex for continuous therapy compared to MPT. And in fact, if you look at overall survival, green is 2, white is 3. Significant improvement in overall survival for older patients and for younger patients. So this difference in overall survival that was seen in the first trial is not just because of those what I would call older fit patients. It actually is contributed to by the older frail patients as well. So again, 2 is better than 3 in this specific patient population. I'm going to wrap up with another trial that looks at 2 drugs versus 3. This is Antonio Palumbo's trial of Lendex versus MPR versus CRP. And the C here is cyclophosphamide, lenalidomide, and prednisone. And again, this was a group of patients where if you were over 75, there was a dose modification or dose reduction built in. And again, if you look in terms of progression-free survival and overall survival, no difference. No difference for 2 versus 3. And in fact, what I would argue is if there's no difference, why are you adding in that 3rd drug? You're only asking for more toxicity. And in fact, that was what Antonio demonstrated very nicely. No difference in PFS or overall survival. And if you break it down by age, the curves are overlapping clearly. And in fact, the 3-drug regimen of MPR was actually much worse. Visually, it was much worse. So if 3 is no better than 2, why are you using 3? 2 should be the standard for older, frailer patients as we go forward. And again, to further identify this, if you look at Antonio's fit, unfit, and frail definitions, you can see the frail patients, which is what I think we're talking about right here, clearly no benefit for the 3-drug, whether it's cyclophosphamide or melphalan, in combination with lenalidomide and a corticosteroid over simple, easy Lendex. So again, this is not a talk about all patients with myeloma. This is not a debate about younger transplant-eligible patients. This is a debate about older, frailer patients, the patients that many of you all see in the community far more frequently than we see in our offices on university campuses. And in those patients, you have to take frailty into account. In older patients where high dose is not an option, no evidence exists to support 3 drugs due to enhanced toxicity of 3 versus 2. And so in my mind, 2 drugs should remain the standard for older, frail patients. I'll stop there.